Okay, I'm going to invite anyone who wants to stand up to go ahead and stand up, since I know we're at the home stretch, and see if anyone takes me up on it. So nothing to disclose. We're going to talk about, I'm going to go through really quickly, describing the eligibility requirements for adolescent bariatric surgery, because I can't talk about this without saying that, because I always get the question. Then we're going to talk about what enhanced recovery after surgery is. And this is, you'll see patients getting ERAS protocols more than just in bariatric surgery. And then we'll talk a little bit about the perioperative nutritional expectations for our adolescent bariatric patients. So who's an eligible candidate? The NIH has guidelines. It's a BMI over 40 or a BMI over 35 with a major comorbidity, such as diabetes or hypertension or NAFLD. We like to see them at 95% skeletal maturity. Everybody asks what age. That's actually a very fuzzy question right now. We haven't really done anyone recently under 13 has been the youngest age. We have some patients, we'll take them into our bariatric side sometimes a little bit earlier, or put them on the medical side and move them over, because we have the advantage of being one comprehensive program, both medical and surgical. And then we have our Strong for Life guidelines, and really the patients need to be ready. They need to be emotionally ready and evaluated, and you met Sheath already earlier today, and she's a big part of that. And they have to understand what's going to happen to them, and the patient and the family have to demonstrate healthy lifestyle changes. So a little bit into enhanced recovery after surgery. So this really started with the adult colorectal surgeons about 20 years ago to decrease length of stay and improve outcomes. And this is just a paper, a screenshot of a paper that was written out of our pediatric surgery group, along with the anesthesiologists, looking at it in pediatric colorectal surgery. And we've actually taken these elements of enhanced recovery and applied them to bariatric surgery. This is the primary operation that we do, so I'm mostly going to be talking about patients that get a laparoscopic sleeve gastrectomy. So we start pre-op, and the very first thing we do to enhance their outcomes is we put them on a protein-sparing fast, which is a liquid meal plan for 10 days prior to surgery. Many of our patients actually say that this is the most difficult part of the whole journey, as you can imagine. So you may actually get some calls from some of our patients, or may have, about this. But this diet pre-op has actually been shown to decrease complications. So in bariatric surgery, I'm working up under the liver and on the stomach, and it actually decreases the carbohydrate loads, so that you actually decrease the glycogen stores in the liver, so that there's actually more room to work. I think this is, as far as I know, this is mostly a mechanical advantage, but it's actually been shown in prospective trials to decrease complications and improve outcomes. So then the next step actually starts in the pre-op holding. And we give the patients gabapentin. We use a lot of Neurontin. And this is across all the ERAS protocols. You'll see this both in the colorectal area, in bariatric, and anywhere else, and anyone else actually undergoing major surgery that we're implementing ERAS. Now, one of the challenges about gabapentin, it's really easy to get the pills, it's really hard to get the liquid. So that's actually one of those things that we found out the hard way, that you need to write the prescription before the patient comes to the hospital so they can get it filled at a compounding pharmacy. The concept of NPO after midnight is gone. So it's now 8 hours for solids, and then we actually give them a carbohydrate drink. We give them like a sports drink about 2 hours before. We haven't quite implemented this yet in the bariatric population, but we're looking at it, and you have to get anesthesia buy-in for that, as you can imagine. And then we also use VTE prophylaxis in appropriate patient groups. And this is actually really one of our patients in the pre-op holding area, giving us a thumbs up before he goes. Intra-op. Anesthesia then goes ahead and gives IV ketorolac and IV acetaminophen, and we use a lot of local anesthesia. They try to limit narcotics and use a balanced anesthesia. Narcotics slow the gut down, which means that you wake up slower and you're not moving as fast, and your gut's not working, so you can't eat as much afterwards. Hydration intra-op. It used to be, oh my gosh, we got this big, huge fluid deficit. They were NPO all night. Well, now that we do all these things laparoscopically, the intraoperative fluid requirement is actually less. And the anesthesiologists have gotten cognizant of that, because if you give too much fluid intra-op, again, you get generalized edema, the bowel gets edematous, and it doesn't peristalse as well, leading to post-op ileus. And again, we continue with VTE prophylaxis. Post-op, and this is actually Carson post-op, he's lost 100 pounds here, and he's actually subsequently lost another 100 pounds. pain, we send them home on gabapentin 300 PO/BID times 5 days. And it's really important that they do this because it really keeps them from having to use their narcotic for breakthrough. In our recent cohorts of patients, it's actually pretty rare for our patients to take any narcotics after this major abdominal surgery. Limited IV hydration in the hospital while they're there, and then we continue VTE prophylaxis until they're discharged. So on discharge, again, the gabapentin for 5 days, we use ibuprofen and acetaminophen, and very little narcotic for breakthrough. They go home when they can tolerate 4 ounces of a non-caloric clear liquid every hour. We treat nausea aggressively because we want them eating, drinking, or whatever they need to be doing, and we happen to use Zofran ODT. Everybody goes on ranitidine. The sleeve gastrectomy is, especially in the perioperative period when you have swelling, almost all the kids get reflux. It's not just when they're symptomatic, they take it whether they need it or not. We want things going down, not back up. And we also get them out of bed immediately. And we limit them to strenuous activity for a month. The greatest thing is, these kids are so motivated. The kids we see are just so wonderful. One of their first questions is always, when can I go back to the gym? It really is awesome. So then we undergo a post-op diet progression, and this is probably where you may see some of these patients. And it really goes from clears all the way up to normal food. The progression is about 6 weeks. Most of the kids get to this by about 4 or 5 weeks when they see us for their post-op visit. But again, this is, we tell them this is for their safety. The stomach, if you think about it, the size we make the tube, we tubularize the top part of the stomach, leave some antrum. It's about the size of their thumb. So if you think about it, you put that and a little bit of post-op swelling there, that's why we do this. It's really for their own comfort and for their safety. But using this ERAS protocol, we actually decreased our length of stay, our median length of stay, from about 2 days to about 1 day. So it's decreased our length of stay by 50%, and the kids are going home in a lot less pain and doing a lot better. And it really is this multidisciplinary sort of approach with anesthesia and the surgeons, and then also taking that through into the looking at a pre-op and post-op. And again, you're going to see this not just in my bariatric patients, but we do this in all of our colorectal patients, the IBD patients that Stan sends us. They all get these protocols. You'll see kids leave the hospital with a total colectomy on post-op day 1 or 2. It's pretty remarkable. So what about long-term nutrition in these kids? So it really is the same as pre-op. It's all the healthy habits. How many of you in here have had Strong for Life provider training? Yeah, that's it. So you know what to do with these kids. They generally eat smaller portions. They can, it's typical for them to say, I can eat, once things settle down, it's typical for them to say, I can eat half a sandwich, or they can eat like a saucer or a salad plate of food. So it's smaller portions, but it's still in the same proportion. Some of the things we need to emphasize are protein first. So they need to eat, because we always tell them you're going to lose your hair if you don't eat your protein. I say, see what happened to me. But so that's real important, because they need to get the protein in. And then we also have I forgot to put it on here, but we also supplement vitamins, because we do worry about vitamin deficiencies. It's not as critical as it is with a Roux-en-Y gastric bypass, where you induce malabsorption, and you have a higher risk of things like beriberi and stuff like that. But still, those are we follow vitamin levels and things like that long term, and it's very critical that they take their vitamins, but then also that they sort of maintain that plate method and eat their protein first. So I'm actually may get you out of here almost not too late, because that's my last slide. If anyone has any questions or has any patients or anything, you're welcome to contact me or Dr. Stephanie Walsh. Stephanie's our medical director of Strive for Life, who's sitting right at that table right there. Thank you very much.